Good afternoon to you all. I'm Dr. Sandeep Kumar from Shaw Eye Center, and we will be discussing our project on Densiron Xtra for recurrent retinal detachment. No financial disclosures. So, since its introduction in 1960, silicone oil has been effective internal tamponade in treating RD. The success rate with superior RD has been around 95 to 100%, but when it comes down to inferior detachment, the success rate falls to around 80, and when it is combined, it is accompanied by PVR, then it can be as low as 30%. Inferior RD with PVR have always been a challenge for VR surgeons because of the inadequate inferior tamponade associated with lighter than water tamponades like silicone oil that leads to inefficient cover of the inferior retina, leads to formation of PVR soup, and it is more pronounced when there is subtotal filling. So to counter all this thing, heavier than water silicone oil tamponades were introduced. The earliest heavy tamponades tried were fluorinated silicone oil. They received a major backlash with the heavy PVR changes, emulsification, inflammation, and raised IOP. So they were withdrawn. Then in the early 21st century, new heavier than silicone oils were introduced. They were a combination of semi-fluorinated alkanes or alkenes and high viscosity silicone oils. They promised and delivered adequate tamponade, lesser inflammation, and others related complications that were mentioned in the literature. Now, Densiron Xtra is a relatively new addition to the silicone oil group. It's a colorless, homogeneous liquid composed of ultra-pure silicone Xtra and F6H8. The heavy silicone oils, they have faced criticism for their complication rates, especially the raised IOP, inflammation, and in situ emulsification. Densiron 68 in particular has found to be associated with inflammatory reactions in the anterior chamber, sometimes leading to fibrinous membrane formation. Whereas Densiron Xtra, the chemical composition of the Xtra helps minimize the risk of silicone oil emulsification. It has got a thixotropic behavior, and the main component, the additive component, is Silicone Xtra, which leads to lower emulsification rates, higher resistance to emulsification, and a lesser injection time when compared to Silicone 5000, which is used in Densiron 68. Now, this is a table describing the 68 versus Xtra, which shows Silicone Xtra is the main component in Xtra and Silicone 5000 in 68, and it has got 68 has got more viscosity and more emulsification rate than the Xtra thing. So when we looked at, there was no study in the literature evaluating the safety and efficacy of Densiron Xtra as a heavier than water tamponading agent. Our study objectives were to analyze the effectiveness of Densiron Xtra heavy silicone oil in managing recurrent retinal detachment, evaluate anatomical and functional outcomes and complication associated with Densiron Xtra, and compare with existing HSOs, especially Densiron 68. The study was conducted at Shaw Eye Center, and 19 eyes of recurrent retinal detachment were enrolled. The study design was retrospective, non-comparative interventional study, and they were followed up for 6 months post-Densiron Xtra removal. Routine revitrectomy was performed for all the patients. 2 eyes with redetachments with Densiron in situ underwent revitrectomy with membrane peeling, and in them the Densiron was removed and replaced with silicone oil 5500. After the initial post-op period, the patients were followed up 1, 3, and 6 months. The BCAA was recorded at the end of 3 and 6 months. 6 months following Densiron removal, the final visual acuity was taken. Patient were also evaluated for any complications. The success rate was defined as stable attachment 6 months after Densiron Xtra, and secondary success was defined as stable attached retina after 5500 oil removed without further intervention and no PVR changes. Okay, so 18 of the 19 eyes that we involved had inferior break. 1 patient had both inferior and superior break. All 19 eyes were of macula of redetachments. The patient with superior breaks had a total RD, whereas 18 other had inferior RD. Subretinal bands were seen in 8 out of 19 eyes. The visual recovery was statistically significant. Anatomical success was achieved in 89.4% of cases. Redetachment Densiron Xtra in situ was noted in 2 out of 19 eyes. These 2 patients had anterior PVR changes and circumferential bands. The mean time of Densiron removal was around 5 months, and following second surgery, there was a 100% attachment rate at the conclusion. Now, PCO, cataract formation, and increased IOP were the 3 most common complications that we encountered. 2 eyes reported post-operative inflammation. Topical steroids were used to control them, and they got easily controlled. Densiron emulsification was reported in 1 eye. 1 eye with post-trauma retinal detachment reported hyphema of grade 1 in the post-op period. Ocular hypertrophy was not reported in any eye. 1 eye reported ERM formation that didn't require any intervention. There was no case of endophthalmitis. These complication results were either comparable or lesser than D68 that have been reported in literature. Retrospective nature of the study, lack of randomization, and smaller number of patients are the limitation of our study. So to conclude, Densiron Xtra with its lower viscosity than Densiron 68 allows easy injection and removal. Densiron Xtra is associated with a lower incidence of emulsification, inflammation, and glaucoma than 68 and other HOs. Our study results support the relatively inert and non-inflammatory nature of Densiron Xtra, and it is expected that the result of our study will be groundwork for future studies with Densiron Xtra. Thank you. Thank you, sir.
I need to comment on that. So the message which should go is not particularly, what kind of Densiron you are particularly using, but in cases of redetachment.
Inferior, especially into the PRG.
What you need to do is more of meticulous vitreous-based shaving and getting the vitreous base out. Getting the vitreous base out and doing meticulous vitreous-based shaving rather than the particular choice of template. I would like to ask you regarding the membrane formation. In which area did you see the membrane? Because
the redetachment cases?
No, there was some membrane thing which you had mentioned.
There are two cases. That was about the patient, those who have redetachment. They have anterior bands, loops, and circumferential bands in which they got Densiron C2 and redetachment. There were those two cases.
All right.
Yeah. So we did a retinectomy and then took out Xtra. And
Densiron, it's in the superior area, where these kind of membranes and these kind of PVRs form, because of course it's
yes, sir. Either it can be. We try to keep the filling. But if there is any suboptimal filling or there is any missed break or something, then it can lead to a gap in between retina and the extra phase. That can lead to those formation of membrane. That is the concept behind PVR soup.
I think as a competitive paper, whenever you are presenting, you should not identify your institutes as well as the,
Sure.
you should never have your hospital as well as the last one.
Okay,
That goes against the protocols of
Okay, sir.